Relapsed and refractory older AML patients have very limited treatment options. Historically, we have been using chemotherapies in patients who can tolerate it. This is a very difficult proposition in the older AML, especially those above 65, 70, because they may have high early mortality from mucositis infection. So using Ara-C anthracycline-based treatments in the relapse situation is an option, but we often see early mortality rates of 15 to 20% or higher. We've also used hypomethylating agents in these patients, but the issue is many of them will get a hypomethylating agent such as azacitidine, decitabine up front, and so these options are limited in the relapse setting. We've had a number of trials that have evaluated this population, but really there is no major breakthrough. I think the two subsets for which we do have effective therapy that is safe are patients with an FLT3, FLT3 mutation, IDH1, IDH2 mutation, and even if those patients are older, up to 80, 85, we can give them an FLT3 inhibitor, such as gilteritinib, or an IDH1, IDH2 inhibitor, such as the enasidenib, ivosidenib, and get response rates of between 30 to 50%. But aside from those two mutational groups, we have very, very limited and almost no real good options for elderly relapsed AML. So Idasanutlin is an MDM2 inhibitor. The MDM2 pathway is a very important pathway in modulating p53 functioning. TP53, as many people know, is called the guardian of the genome. It plays a critical role in cell differentiation, proliferation, maturation. And what we see is that the MDM2 inhibition removes the brakes that MDM2 normally puts on TP53. So it basically allows TP53 to continue its function or function at a higher level. And because of that, we see that there is normal cell maturation, differentiation, proliferation is under control, and it also plays a major role in controlling apoptosis. So by having TP53 function maintained or increased, we can actually get increased pro-apoptotic signaling through markers such as BAX, BUMA, PIM, etc. And it also plays an important role in promoting MCL1 degradation. So has multiple different modalities of action. What's really important to know with this agent is that it usually will not work well in people who have a TP53 mutation. So all of us are used to thinking about mutationally targeted therapy. This is almost a reverse selection where we actually do not want or would preferably not give a TP53 mutation patient a MDM2 inhibitor. So that's just important to know. Venetoclax is a BCL2 inhibitor. It has shown very striking breakthrough activity in frontline older AML patients, especially combinations of hypomethylating agents such as azacitidine or decitabine with venetoclax or low-dose-cytarabine with venetoclax have shown response rates 3 to 4 times higher than we would get historically with single-agent azacitidine, decitabine, or low-dose-cytarabine. And this is now US FDA approved and has shown great activity. However, we do see that there are about 30-40% patients who are resistant, and there may be a subset of patients who may relapse early, especially those who have certain mutations, FLT3, RAS, others. Now, our group at MD Anderson did a lot of preclinical work and showed there is a huge amount of synergy between MDM2 inhibition and BCL2 inhibition. And the mechanism for that is that when you do BCL2 inhibition, one of the major pathways of resistance is MCL1 upregulation. So if you block one anti-apoptotic pathway, the tumor escapes by upregulating the other anti-apoptotic pathway. And the way we can try to block MCL1 is usually by doing MDM2 inhibition or by using direct MCL1 inhibitors. Now, we do have trials using MCL1 inhibitors in combination with venetoclax, but the benefit we may be getting with MDM2 inhibitor combination is that not only does it promote degradation of MCL1 through MAP kinase pathway inhibition, but also it has a double whammy activity because it also independently increases pro-apoptotic signaling through BAX, BIM, PUMA, and that further stabilizes the MCL1. And also we seem to see a better safety profile and less cardiac toxicities with MDM2 compared to MCL1. So this is the rationale which has been published by our group in Cancer Cell that has led to this combination. So the phase 1b study was developed in older relapsed AML. So this is a very difficult population. They're older patients, which are always difficult, but they're also relapsed. And the study was looking at identifying the optimal dose of the combination based on the preclinical synergy we had seen with Idasanutlin and Venetoclax. So the study is currently in a stage where we're trying to finalize the optimal dose. We have looked at 4 or 5 different dose levels, and it looks like the Venetoclax at 600 milligram daily with Idasanutlin either 150 milligrams day 1 through 5 or 200 milligrams day 1 through 5 may be the optimal dosing schedule. At that optimal dosing schedule, we are seeing marrow remission rates, so this includes CR, CRI, MLFS, of almost 50% in about 30 patients treated at that dose level, which is much higher than the expected 15 to 20% we would see with standard of care therapies in relapsed older AML. Also, the regimen seems to be well tolerated. The early mortality, 30-day mortality is 6%, which is acceptable and lower than what we see in most relapsed AML elderly studies. And the safety profile also is quite well tolerable, the main side effect being GI toxicity, mainly nausea and diarrhea, but only 3 to 4% of these were grade 3. The majority were grade 2, and with routine prophylaxis being done in the first 24, 48 days of Idasanutlin, which we now mandate in the protocol, we see the grade 3 diarrhea has gone down to 0. So the study is now going to go into expansion. We are going to look at a intermittent schedule where we could maybe reduce the duration of Ven once a patient achieves a marrow clearance if they have hypocellularity or neutropenia, and hopefully that will even further improve count recovery and the CR/CRP rates. One of the nice things about this study is that it kind of emerged from a very exciting and well-done preclinical translational work. And so it's one of the true examples of translation from bench to clinic. But also, since the study was very scientifically developed with a lot of input from lead investigators across the world, we have a very robust platform for correlative analysis. So we are collecting all baseline bone marrow and blood samples as well as longitudinal samples on each subsequent bone marrow and the time of progression. And we are doing a 250 gene foundation heme panel. And in addition to that, we're also looking at other RNA sequencing-based profiling, BCL2 protein-based profiling, BH3 profiling, and a lot of this data will emerge. What we do have at this time that we presented at the ASH 2019 is that there are baseline mutations that seem to predict for sensitivity, the most important ones being IDH1, IDH2, RUNX1. These are also the same mutations that have consistently predicted for sensitivity to HMA or low-dose Ara-C Venetoclax, so this is a consistent profile. And then there are certain mutations, especially signaling kinase mutations like FLT3, RAS, NF1, which all end up activating the MAP kinase pathway, as well as TP53, which cause resistance. In this case, TP53 is especially important because we do know that if you have a mutated TP53, MDM2 inhibition may not be functional or as functional, and we think that these patients may not have the same degree of benefit as non-TP53.